guess many of you know these situations. A patient comes in, he's critically ill, and you do not have all the time in the world, but you need a diagnosis. The CTs may be busy, or maybe you don't even have a CT, and it would also take too long until you finally get the diagnosis from the radiologist. Well, this is exactly where ultrasound comes into place. Point of Care Ultrasound is something that you can use in so many settings. And I'm very, very happy to guide you through this crash course together with Martin Altersberger.
Thank you very much, Tommy. It's a pleasure to be here, especially in these difficult times we are facing with COVID-19.
Yeah, that's absolutely true. I've been talking to so many colleagues out there, and there's a definite need for support. And we believe that Point of Care Ultrasound can definitely help out there, help our colleagues and friends to maybe fight this battle against COVID-19.
Let's jump right into the topic. What is Point of Care Ultrasound? Point of Care Ultrasound is a specific exam where you do it symptom or sign based, where you, for example, have a symptom like dyspnea, and you use distinct devices. For example, a device like this, a handheld device, which of course is very, very useful if you want to do an exam at the bedside of the patient. But is it the only device we can use?
Well, definitely not. But let's take a look. So what you see here are 4 distinctly different scanners.
We have here, for example, a laptop machine. This is a probably mid-end machine. It is portable. You can remove it from the rack. You have various types of probes. And of course, you can use it bedside. You probably might know it from your intensive care unit. Here we have another portable machine. You can also remove it from the rack. You see again various types of transducers. And the big advantage here is the touch screen. So only by touching the screen you can change your settings and your image. Using this, you can really use it bedside, even in a sterile environment on your ICU.
This is a very similar scanner. It has a larger screen, which is obviously good because sometimes you need to image patients from further away. It has a longer battery life, and it is also a scanner which is easy to disinfect and use in your intensive care unit. And here we have a scanner which is an all-round machine. However, focusing cardiology, that's something that I as a cardiologist of course like to use. It has many features specifically designed to look at the heart, but you can image other patients of course as well and other organs. So depending on your setting, you would choose the machine.
Of course, it's very important to know and to understand that you can use any kind of machine. But the most important point is that use your machine, get used to your machine, know the settings of your machine, and also the technical limitations, but also the limitations of your exam.
So I would say in principle, it's always a balance between the image quality and the advantages of mobility. Of course, it always depends on which setting you work in and what your experience is, and definitely which organ and what focus you have when you want to investigate a patient. So Martin, you were talking earlier about the different approaches of point of care ultrasound. Can you explain what kind of approach we could really use?
Yes, of course. There are several approaches, and first of all, I want to mention the symptom dyspnea. Think about dyspneic patients. How many do you see each and every day, especially in the COVID-19 situation? If you think about patients with dyspnea, you have to, of course, think about many differentials, so not everyone will have a viral disease. They can have heart failure, they can have pleural effusions, with or without pneumonias, they can have a pneumothorax, kidney disease, liver diseases, and many, many more. So an approach where you look symptom and sign based to try to rule in or rule out various diseases.
And with POCUS Ultrasound, you'll be doing just that. You'll be looking at every different possibility there is and try to either find the reason or to exclude an important pathology.
Another approach is point of pain. It's quite simple. You ask a patient, where does it hurt? And when a patient answers you, for example, in the right upper quadrant in a car accident, we are going to take a look if there is a lung contusion, or probably there is free fluid or a broken rib. Also a pulmonary embolism. Where is it located? Just use lung ultrasound. Or for DVT, compression sonography. Also flank pain, is it hydronephrosis? In the right upper quadrant, the sonographic Murphy sign for cholecystitis. All of this you can use point of care ultrasound.
So in principle, it's almost like performing a much more thorough physical exam that you can do with your hands or with a stethoscope.
Of course, there are many more indications. For example, procedural guidance, when you do a thoracocentesis. In resuscitation, also in deciding to terminate resuscitation. In monitoring diseases, for example, pleural effusion or pneumonia. Of course, in any kind of emergency situation.
Right. I mean, of course, we will not have the time to go into all of these different points. We'll focus on those topics which are most important. But I guarantee you, once you start using ultrasound, you'll get addicted to it and you want to learn more.
The topics we are going to cover are part of the EFAST exam. So we will look for free fluid, but we will adapt it to a physical examination. And we will do some extra scanning to visualize the gallbladder, the aorta, and also the lung and COVID-19. What we want to present to you in this two-part free lecture series is an extended version of an EFAST exam.
So let's not lose time and let's go right to the scanner.
Before you start scanning, be aware that you always stick to the hygiene protocols of your hospitals. In regards of point of care ultrasound, patient positioning is very important. If the patient cannot move, you of course have a supine position patient, but you can also move the position to a left lateral position or a right lateral position or in a sitting position. It always depends on what the patient can do. Also be aware that you have to think about what you want to image. If you want to image the heart, you might want to choose a left lateral position because that's better for cardiac ultrasound. In abdominal ultrasound or an EFAST exam we are performing it now, a supine position patient is perfectly fine. Let's take a look at the machine we are going to use. Be aware that we have several probes we can use for various applications. Here we have a convex probe. Here is the marker. This is used for abdominal ultrasound and also lung ultrasound. We have a linear transducer for more superficial structures, for example, vessels. Also for lung ultrasound, for the evaluation of pneumothorax, you can use a linear probe. And we have a cardiac transducer, which is a bit smaller than the convex probe because you have to scan intercostally. Let's have a look at the machine. We see here various settings. We see a depth setting. We have a focus zone. Here we have an image of the marker. And now let's see what kind of image we can create. We can use ultrasound gel. Always use enough gel. And now we place the probe. We can use the freeze button to freeze the image. And you can use here the settings to travel back and forth in time. So let's use the freeze button and optimize the settings. What do we see? We have a depth here of approximately 30 centimeters. If you look at our patient, the patient is extremely slim, so 30 centimeters is far too much. So we have to reduce the depth. We can adjust the focal zone as well, and 15 centimeters is way better. Now we see the image is really dimmed, it's dark. We cannot differentiate the organs properly. So we have to use a second setting, that's the gain setting. Be aware to not overgain too much, because if everything is just hyperechoic, so really bright and white, you cannot differentiate the organs properly. Also, don't use too little gain, then we are back in the situation that it is way too dark. So you have to find a setting where the vessels are still black. So fluid in ultrasound is black.
Don't worry, the technical stuff is not so difficult to understand, and once you start using the scanner, you'll learn.
Exactly. So let's start with the first part of the EFAST exam, the right upper quadrant view, Morrison's pouch. Before we start scanning, we have to choose the preset, in this case an abdominal preset. We have the convex transducer, and we have here a little notch on the transducer that is resembled by a symbol on the screen. We can place the probe on the patient and we see an image. Maybe we can even reduce a little bit the depth and increase the gain, just not too much. And now let's have a look at the anatomy. What we see immediately here is the right kidney. The view is blocked by ribs and rib shadow. Here is the liver, and this is cranial and this is caudal. This is close to the transducer, so the near field, and here we have the far field. Now please inhale deeply, and you see as the patient inhales, all the organs move caudally. So we achieve a better view of the right kidney over here. And also here we see the psoas muscle, and as the patient breathes in and breathes out, the kidney is sliding on the psoas muscle. Let's move more cranial to visualize the Morrison's pouch. The Morrison's pouch is the space in between the right kidney and the liver. Here very often you see free fluid initially. Other pathologies you might find here are hydronephrosis or kidney stones.
But what is the clinical importance of the Morrison's pouch?
Well, the clinical importance is very easy. Free fluid very often accumulates initially in this area. So over here in between the right kidney and the liver, this is the Morrison's pouch. Free fluid would appear as an echo-free area. Furthermore, take a look at the liver to detect liver disease as well as kidney disease. Furthermore, you can see the psoas muscle over here.
So in essence, you have one view and a lot of information.
Keep in mind to always rotate and turn the transducer a little bit to really see the whole pouch of Morrison, and also move a little bit cranial and caudal and have a transverse view of the kidney as well. It will tremendously help you in detecting free fluid.
In which setting would we use this view?
So, for example, here we have a nice view of the right kidney, and here the same view. And look at the psoas muscle. As long as the kidney is sliding like this on the psoas muscle, that's normal, that's physiological. If that stops, there could be an abscess. Another pathology, an important pathology you can visualize in this view is hydronephrosis. We have here an example of hydronephrosis grade 2, and here hydronephrosis grade 3. So a dilatation of the renal pelvis and the calyces.
Right, the echo-free areas, that is where fluid is accumulating.
Another very obvious and very common pathology are simple cysts. This is a kidney full of cysts. Look at these echo-free areas. Some are huge, some are smaller, but we are aware they are all entirely black, so uncomplicated cysts.
And be aware that these cysts can sometimes become very, very large and cause abdominal pain.
In this view, measuring is also possible. For example, here's a measurement of the right kidney. The normal measurement of the right kidney is 10 to 12 centimeters. Be aware that you really have to measure the whole extent of the kidney.
Just as in other imaging modalities, measurements are very important. Now, in point of care ultrasound, there are a few that you will have to remember. But don't worry, there are not a lot. To summarize the right upper quadrant view, Morrison's pouch, try always to have more than one view. The more views you have, the more idea you really get of a pathology. Look for free fluid initially at the right upper quadrant, and be aware of the other pathologies you can find, like hydronephrosis, cysts, abscess, also carcinomas and metastasis, but also kidney stones. But kidney stones are something which are usually much more difficult to detect.
Exactly. There, hydronephrosis is easier to find. Let us take a look at the patient. His name is Friedrich. Friedrich enters the emergency department and says, I had cancer. I lost weight. I have night sweats. I have to change my nightgown 2 to 3 times every night for the last couple of weeks. But I do not have fever, and recently I gained weight again. So let's perform point of care ultrasound. With the clinical information in mind, if we take a look at those views, let's repeat, here we have the liver and the right kidney, a little bit a different angulation at the liver and the right kidney. What would you say? Is this good, bad, or ugly? Well, this is terrible.
Well, unfortunately, this patient has a severe problem. Did you detect where the problem was?
Well, if you take a look at the kidney seems to be fine. But did you recognize the black area over here, the free fluid in the Morrison's pouch? Probably some of you or most of you saw that, but did you also see those hypoechoic areas in the liver? If we scan through the whole liver, we see a greater extent of ascites, the free fluid, and we see many large hypoechoic areas in the liver parenchyma.
I think this example so nicely shows that in one view you can already find so many very important findings which I guess all fit together.
To summarize what we have seen, Friedrich has metastasis of the liver.
But now let's move to another very important view.
Let's have a look how we can detect pleural effusion with point of care ultrasound. For the detection of a pleural effusion on the right side of the patient, we have to position the patient in a supine position, and we take a look at the anatomy again, and we see on the screen the liver and rib shadow, and here we already saw an hypoechoic line. That's the hypoechoic line that resembles the pleural in ultrasound. Now we move cranially and as dorsally as possible to really visualize a pleural effusion. And here you can see the lung and the liver, and the lung moves over the liver and it seems like to be a curtain. So can you inhale and exhale? And you see the whole liver vanishes because there is lung. And it's very important to notice pleural effusion would be a black area where now the arrow is pointing. So if you see a black area in the near field, that points towards a pleural effusion. What we just saw was that we just moved from the Morrison's pouch more cranially and more dorsally as possible. In this case, we have a patient without a pleural effusion. So here is the lung and here the liver, and there is no echo-free area in the near field.
Right down here we see the IVC, by the way.
So even when we look for a pleural effusion, we can already see one of the great vessels.
But how does a pleural effusion look?
A pleural effusion sometimes can be very small. Like in this case, we see there is a little bit of echo-free space over here and over here. So don't confuse this with a pleural effusion. This is ascites. This is directly located at the liver. And here we have still a little bit of pleural effusion present as well.
Now, of course, it can be confusing at first to distinguish a pericardial effusion from an ascites and also from a pericardial effusion, but if you remember where the transducer is and if you have a good understanding of anatomy, I'm sure you can make the diagnosis in most cases.
Important is take your time and, as you said, Tommy, just know where you're located with the transducer.
As a matter of fact, we're very sensitive actually for the detection of pleural effusions.
Indeed, we can already detect fluid 10 to 15 ml. For example, in X-ray, you need 250 ml of free fluid to detect it on X-ray.
Yeah, so ultrasound is the way to go if you want to detect a pleural effusion. And here's an example of a pleural effusion that we also saw on the chest X-ray, a very large pleural effusion. What you can see very nicely here is the diaphragm, and you see that there is a lot of free fluid, probably 10, maybe even more centimeters from the diaphragm upwards.
This example we see is a so-called transudate. That's basically clear fluid, so everything is black. But if you take a look at this example, that is as well a pleural effusion, but that is an exudate, so inflammation. You see these fibrinous layers over here, and here the free fluid as well.
Yeah, this smells like bacteria. So ultrasound helps you to distinguish whether or not pneumonia, for example, is bacterial or has another cause.
But a pleural effusion is not the only thing, of course, we see on ultrasound if we want to detect a pneumonia. In this impressive example, we see a pleural effusion. It's large, but not as huge as we've seen already before. But we see this structure over here. It almost looks like the liver. This is what we call a consolidation. That's pneumonia.
Right, but do we see every pneumonia?
No. Sometimes, especially when there's interstitial pneumonia present or viral pneumonia, it can be harder to visualize and distinguish with ultrasound.
This is absolutely true. And we can also use lung ultrasound to detect patients who have other forms of pneumonia, for example, viral pneumonias. This is one of the targets of lung ultrasound in the setting of COVID-19 infection, for example. In this setting, you would, however, very infrequently see a pleural effusion.
We have seen several pleural effusions. I'm sure you can scan it yourself by now, but we only covered the right side. How can you scan the left side?
Well, Martin is going to show you.
When we scan the left side of the patient, we also place the transducer approximately the mid-axillary line, and we can again identify kidney. So this is the left kidney and this here is the spleen. And in between the spleen and the left kidney, we can see the Koller pouch. On the left side, it's important to notice that free fluid not always accumulates in the Koller pouch, but also surrounding the spleen. So we have to move a little bit more cranial and move the transducer around to really get a good overview of the spleen and of the left kidney. To repeat what we just saw, we scanned the Koller pouch. Again, we were looking for free fluid, but on the left side, you have to scan the whole spleen because the free fluid not always accumulates initially in the Koller pouch in between the left kidney and the spleen. So always scan the whole organ, the whole spleen.
So now we've seen how to detect a pleural effusion on the right side. But let's take a look at the views that we need to detect whether or not an effusion is present on the other side.
For the detection of a pleural effusion on the left side, again, we move cranial like we did on the right side of the patient and as dorsally as possible. And you see the spleen and here you see the lung. And if we ask our patient, can you please breathe in and breathe out deeply? Very good. You see that the lung is again like a curtain. And for the detection of pleural effusion, you would look where the arrow is pointing. So in the near field. If there is a black area, that would be free fluid or, so to speak, pleural effusion.
So what is the difference between the left and the right?
So the main difference, of course, is on the right side we have the liver and on the left side there is the spleen. The spleen is a smaller organ, so you even have to go a little bit more dorsal and more cranial to see the same feature we saw on the right side. You want to see this curtain over here. This is again a patient without a pleural effusion. Take a look at the near field where you see lung and spleen.
As this example shows, no matter if you image on the left or on the right side, a pleural effusion always looks the same.
If it is a transudate, it's an echo-free area, so basically black on the image. Here you can see the same finding, echo-free area. This time we use the linear transducer and here you can see something additional. This is compressed lung tissue. This is atelectasis, waving at you like a waving hand.
So you've learned a lot so far. You heard about the Morison pouch, that we can find fluid that accumulates in this area. You saw an example of a patient with a malignancy, and we now know how to detect a pleural effusion. But this is by far not all.
In the next lecture, we will learn how to rule out the pneumothorax. We will scan the heart. We will scan the Brewster-Douglas cavity. And we will show you some more lung ultrasound loops to show how you can detect COVID-19 with the help of lung ultrasound.
So stay tuned.